There we go. So we've restarted the recording now. Now we're all ready. So I guess for you guys in the room. Yeah, thank you, Daisy. Sorry, continue.
Sorry.
Please go ahead. Sorry, I interrupted you.
Yes, so as just welcoming everyone and yes, thanking them for joining in. So since we are hosting the case presentation, I think we would go first with the introductions, if that's okay with everyone. Hello.
Yes, please go ahead, Daisy. That sounds like a good idea.
Okay, it's fine then. So I'm Daisy Hasasha Nalukowe, a nurse working with K4C, positioned at Kasangati Health Center for. Yes.
Hi everyone, I just came in to support Daisy. I'm Dorothy, a midwife based at Kasangati and a knowledge for change.
Hi everyone, I'm called Babas Doreen, a midwife working at Kasangati Health Center for maternity.
Hi everyone, I'm Ndagire Sarah Terilogosa.
I can't see you.
I'm Ndagire Sarah Terilogosa, working at Kasangati Health Center 4 as a midwife. Thank you.
So that's the team that we are having here. We are supposed to be with the hospital in charge, Dr. Ivan Nyenje, but he's actually in theater working on our clients. So we decided to just go on with a case presentation about him. So I'll share the recording with him later. Yes. Other people can introduce themselves. It's okay.
Let's go to the team in Fort Portal first.
Yeah, I'm Rachel Namuro. I work with Knowledge for Change in Fort Portal General Fire Hospital and also in Kagota Health Center on Neonatal Sepsis. Nice meeting you.
Hello, I'm Tiggy. I'm a UK volunteer midwife. I work in the health centre and on the labour ward at the regional referral. James, we just also wanted to check, did you guys in Kampala find who your virtual volunteer was?
We actually found out the person, but it was a bit on short notice, so we did not manage to invite her. Yes.
I thought we should double check. Cool.
Yeah, we discussed before you joined, Tiggy. I suggested that we try to give Ellie as much notice as possible before the next meeting and share this recording with her as well, so she can hopefully make it to the next one. Is Angela there, or?
Angela's gone to do the debrief with Derek. I'm here.
Right. Sorry, I was pausing to see if Angela was still there to introduce herself. So I'll go next then. My name is James. I'm a research project manager here in the UK, working for the University of Salford, but also supporting Knowledge for Change with the management and implementation of its projects as well. And I'm the interim project lead for this project. It was previously Claire Horder, but she's moved on roles. So for the meantime, it's me. And yeah, I'm hopefully visiting you guys in Uganda in a few weeks' time. Just Alan left to go.
Yeah, I'm Alan Ndawla, working with Knowledge for Change.
So I think those are the
Daisy.
Thank you so much, Alan and everyone. So I think those are the people we are having for this session. So I'll go on to share our case presentation, and yes, I think that's it. Hello, can everyone see the screen sharing?
Yes, we can.
Okay.
Yes.
So
Yeah.
okay, that's good. Thank you so much. So we're going to present our case. Doreen will go first. Yes, the rest of us will be coming in as the presentation goes on.
Okay, thank you so much once again. I'm called Mbabas Doreen, a midwife. Today we're going to present our first neonatal sepsis case from Kasangati Health Center 4. I think I'll go straight to the mother's biodata. By initials, she was NJ, 30 years. She's unemployed. She stopped in Athenia 4. She's single. She comes from Nakwero. By gravidity, she's a gravida 4, para 1, plus 2 abortions. LNMP was 1st of November 2023, and her EDD, that is expectation date of delivery, 8th of August 2024. And she was admitted on 5th August 2024. And by that date, the weeks of amenorrhea was 9 weeks and 6 days. The time of admission was not documented. This mother was discharged on 9th of August 2024. And the reason for coming to the hospital was she came with history of labor-like pains that started at around 2 a.m. on that same day, 5th of August 2024. She also reports seeing some shock, and she had no any other complaints. The mode of transport she used was a taxi, and she was accompanied by her friend. Past obstetric history, stroke line history. This mother had no ectopic pregnancy, no forceps delivery. However, she had 2 abortions, whereby one was induced and the other one was spontaneous with unknown cause. This mother had also at Zambia Hospital in 2024, and the reason was not known. 2014, sorry. Antenatal history. This mother attended 3 times at Kasangati Health Center 4, and the first visit was at 30 weeks of gestation, and that is around 7 months and 2 weeks. When she came for antenatal, she had some tests which were done on her. That was HIV, RPR, RBS, and blood grouping. And the 2 ultrasound scans were also done. However, the Hep B sickling test not done during the visits. This mother also received IPT, FEFO, and mabendazole tablets. And when she came, the MO reviewed her to decide on the mode of delivery, and this mother was given a trial of SCA. Her medical history, she had no any known medical condition. Surgical history, she had no surgeries, she had no accidents, and she was never been transfused with blood. Family history, this mother had strong predisposition to hypertension and to 20 pregnancies, and she had no any other familial conditions. A social history. This mother is currently unemployed. She rents a 2-room house where she stays with her firstborn child who is 10 years old, and she reports being financially constrained and unable to afford even simple basic needs. Both her children have different fathers and are both being raised by her alone. She doesn't smoke and doesn't take alcohol. On admission, the vital observations, the blood pressure was 110/88, pulse was 86 beats per minute, SpO2 98%, respiratory rates 20 beats per breath, 20 breaths per minute. Physical on per abdomen, fundal height was 38/40, presentation cephalic, lie longitudinal, position right occipital anterior, and descent was 5/5. Fetal heart rate was hard, but the rate was not documented. Vaginal, the vulva and the vagina was clean, normal, and warm. The cervix was thick and soft. Os was 2 centimeters dilated. Membranes intact. Pelvis felt inadequate, and the presenting part was still high. And the impression was a Bravida 4/1+2 with previous scar in latent stage of labor. And the plan was monitor labor progress, ambulate, take home sweetened tea. On 6th August 2024 at 9:19 a.m., patient was not on the ward and couldn't be located. That was by the midwife on duty. Then after a short time, that's after some minutes, she relocated. So she was reviewed at around 9:47 a.m. On examination, there was no edema, no jaundice, no anemia, no dehydration. And the blood pressure was 126/82, and the pulse was 90 beats per minute. Per abdomen, fundal height was 38/40, presentation cephalic, lie longitudinal, position right occipital anterior, fetal heart hard. Descent was 4/5. On vaginal examination, the vulva and the vagina was clean, warm, and moist. Cervix was thick and soft. The presenting part was still high, and the pelvis inadequate. And the diagnosis was Bravida 4/1+2 in active labor, querying inadequate pelvis. And the plan for the midwife was review. So when the MO arrived, she also reviewed and noted that this mother, and the MO reviewed and ordered for an emergency C-section due to poor labor progress, secondary to CPD, that is cephalopelvic disproportion. So the plan was made, and the mother was prepared for a C-section whereby the consent was obtained. She was also given prophylactic treatment, specifically was IV ceftriaxone Thank you so much. I'll request Mike also to start from there.
Can you see from here? Okay. You can. You okay? Okay. It's fine.
Thank you, Dorian. The operation notes, birth weight was 3.2 kgs, sex, male, date of delivery, 6 August 2024, the Apgar score, 8 in first minute and 10 in 5 minutes. Time of delivery was not noted, but the operation started at 50 minutes past 1 p.m. Both mother and baby was stable. Instructions from theater: monitor vitals every 2 hours, give 3 liters of IV fluids within 24 hours, alternate tramadol with IV paracetamol for pain management, nil per oral for 6 hours, IV ceftriaxone 2 gram OD for 3 days, IV metronidazole 500 milligram for 3 days, continuous bladder draining for 24 hours. On postnatal ward, mother was admitted on postnatal ward on 6 August 2024. Time of admission was not documented. Mother was reviewed 3 times while on ward by a medical officer, was recovering well with no complications. She received all the prescribed medications and was discharged on 8th August 2024, but stayed to care for her sick baby.
Thank you so much. We shall proceed with the baby. So the baby was stable on 6th of August 2024. However, on 7th, the caretaker reported that the baby had developed a high temperature at around midday. This baby was exposed for 2 hours, but the temperature persisted. The baby was later admitted at 3 p.m. and initiated on 10% dextrose since it was not suckling well. So the presenting complaint when the baby was being admitted was high temperature, a poor breastfeeding pattern, and lethargy, which was noted by the caretaker saying that the baby seemed sick. As per the physical examination, the baby had a poor skin tagger, was febrile on touch, had excessive crying, and a high temperature of 39 degrees Celsius. The vitals, the temperature was 39 degrees Celsius, the heart rate was non-documented, the respiratory rate was also non-documented, and the management plan was made by an enrolled midwife. And in her plan, she had suggested continuous monitoring of vitals, exposing the baby and giving 20 mils of IV dextrose 10% every 2 hours. On the first day that baby was given IV dextrose 10%, 20 mils, and the baby received this only 3 times on the first day. No other medication, no other documentation of the baby's vitals besides the admission temperature was in the chart. Then on the second day, the baby was given IV dextrose 20 mils 4 times and ended up latching well. However, the temperature was recorded at 38.8 degrees Celsius. So the midwife enrolled the baby on IV antibiotics, and the baby was given IV ampicillin 320 milligrams twice a day, and also given IV gentamicin 16 milligrams once for the second day. On day 3, the baby continued with IV ampicillin 320 milligrams twice, and also Genta 16 milligrams once. The baby was later discharged after completing the dose on the second day. And in total, the baby had been on treatment for 3 days, but 2 days on antibiotics. So that's like the end of the case presentation. But there are some things that we had discussed as a team that I will just briefly go through. For the IPC measures that were observed in this case, we realized that there was a central sterilization system at the hospital. Then the baby was also received in sterile clothing, and gloves were also provided in theater, the sterile gloves, during the operation. The mother noted that she had washed and ironed the baby clothes. Then there was also proper scrubbing in theater prior to the surgery. So probably that's why the mother did not also get sepsis after the surgery. Then the positive aspects that we noted from this case, the client only had 2 vaginal examinations, and that would also reduce on the risk of the neonatal sepsis. Then also the choice of antibiotics was as per the Ministry of Health guidelines, the Ampigenta. Then the baby was first managed using dextrose before switching to antibiotics. So realized that there was proper use of antibiotics, because also a baby who is not suckling well and is hypoglycemic could also have a spiking temperature. Then the decision for the emergency cesarean section was timely. When the enrolled midwife realized that the pelvis was inadequate, she reached out to the MO who made the decision to have the emergency cesarean. The medical officer reviewed the mother at postnatal ward. The mother was on ward for some days, so every time during the morning ward round, the MO would review and also see if the mother is progressing well. In our near misses, we looked at the time frame for the prenatal period. We realized that this is a mother who came in at 7 months of gestation. So probably she did not prepare herself so well before the pregnancy. And that leaves us to question also the medication and the nutrition that she's supposed to be having before the pregnancy. Because we realized in our risk factors for neonatal sepsis, there is something to do with malnutrition. The baby will have a low immunity, and also the mother is supposed to be taking drugs like folic acid before the pregnancy. But if someone is showing up at 7 months, you are even at a risk of the baby having congenital anomalies. So something just happens normally, but this is also a big risk. So this mother did not have proper education before becoming pregnant and did not prepare for the pregnancy. During antenatal visit, in the near misses that we saw, the mother started late for antenatal at 7 months, but even she ended up having only 3 antenatal visits that are even way below the ones that are recommended by Ministry of Health. So the care that she got during the pregnancy was not actually adequate. And then the tests like hepatitis B, the sickling test, TT, they were all not documented in her antenatal card. So we do not actually know if she got these. Then there was also no proper fetal heart rate monitoring. On the antenatal card, all that was being put was fetal heart rate hard. So yet this was a term baby, someone who is at 7 months, most of the organs have already grown. So it's easy for you to actually tell the number of the fetal heart rate for the baby. So in case a baby has complications, it's hard for you to tell if you just put fetal heart rate hard. Then during the labor and after the labor, delivery, and after delivery, still even in her chart, the fetal heart was not being quantified. Yet this was prolonged labor. So it's just by chance that this baby did not go into distress. Yes, so that's something that we noted. Then there was also delay in receiving appropriate care as the baby only received 3 doses of dextrose. The choice to start with dextrose was, I think, okay, but if the midwife had made a plan of 2 hourly doses and the baby ended up having three doses, I think that was also below the requirement. Then there was also no proper neonatal assessment that was noted in the baby's chart. For a baby who had spiking temperatures, only having vitals, the temperature being monitored, a recording of 2, that was also not really okay. Then the baby's vitals were not monitored, just even besides the temperature, the heart rate, because if a baby is having a sepsis and it ends up becoming complicated, some of these vitals can help you decide on the referral, decide on the changing on the treatment plan. But if this was not done, it's just we just got lucky. Then the breastfeeding pattern was not really monitored. It's only when the baby was breastfeeding well that, yes, the dextrose was stopped. But before that, the latching, cleaning the breast, because we also noticed that if the baby is not feeding from a clean breast, that would also put them at a risk of getting sepsis. So this is a mother, when we talk to her, this is a mother who would have actually benefited from teaching her how to clean the breast, how to latch the baby, but that was something that was not done. Then the baby also only received antibiotic therapy for 2 days. We had gone through the Fort Portal team presentation, and I think they had said at least the baby should receive 3 days antibiotic therapy, but this baby only received 2. 7 would be the ideal, but at least 3 days. So ours was even below the 3 days. Then the baby was not reviewed by the MO while on ward. So in the baby's chart, the only writing that was there was for the midwife. So that cannot help us ascertain if the medical officer actually reviewed this baby. Then the mother was also not educated on cord care. Then also the lab tests were not done to confirm the infection and isolate the organism. So for us here, we have a lab that can actually do the RBS, the CBC. We may not be able to do the cord swab or the C-reactive protein or the blood cultures. That might take a bit longer, but just CBC and RBS, that's something that can be done here, but it was not really done, I think maybe because of the short staffing. Then the thermoregulation was also not documented. Then also inadequate personal protective equipment, that is for the gloves. This is mainly at the postnatal ward. And also at postnatal ward, we don't have a sink for hand washing, but there is no provision for the hand sanitizer. Some of these things are also beyond us, but those are things that we're thinking about. If there is no proper hand washing facility, the caretakers like washing their hands, how are they attending to the baby? So those are things we were thinking about as the near misses. Then overall, the staff who were able to manage this, we had 2 medical officers, the one who reviewed and went for the cesarean section, obviously with the team in theater, the anesthetist, the nurse receiving, the midwife. And then in total, most of the people who are attending to this client, both the mother and the baby, were enrolled midwives, and there were about 5. Our health facilities at a health center for, so we don't have specialists like the pediatricians, yes, or the gynecologists. We only have medical officers. So that was our case. I don't know if people are still listening in. Hello.
Sorry, were you trying to say something then, someone in Tiggy's team? Maybe we've lost them temporarily.
Because we're still listening. Daisy said she didn't know if we were listening.
Oh.
So I would like to get a feedback maybe.
I think maybe the team in Fort Portal are having some connection issues. I had a question actually, just while we are waiting to see if they can reconnect. I was really interested to hear from your case presentation about the background to the mother. You know, right down to a lot of detail about her family, her children, her socioeconomic status. Where did you get that information from?
So we actually, on the patient file, there was a phone number. So we based on the risk factors, things that we were thinking were important. So we called her and we talked to her, we introduced ourselves, then we told her we just wanted to find out some information about some things. So that's how we got to ask her about her living situation and employment.
So is that what you would you do that for other patients, or did you do that just for this particular case?
I think we might actually have to do it for a few of the cases, because in the risk factors, the socioeconomic status is really important, especially for the infection that comes, the late onset, and also even the prenatal period and the antenatal period. It could lower the immunity of the mother if she cannot afford some things, or if she's not feeding well. So that puts the baby at risk of getting sepsis, or not actually easily fighting off the infection. So that's something that we thought was maybe important. And we might have
I agree. I think it's very, very important. The reason why I'm asking is because we had a discussion yesterday in the Fort Portal case review meeting about, because someone made the same point, can we collect data on socioeconomic status? And at the time, I thought that would be very difficult because it's not readily available in the patient notes. But it sounds like you guys have gone a step beyond and already contacted the family, which is really, really interesting. But I'm just wondering whether that would be feasible to do for all case reviews, because we would need to do the same for all of them really to make them standardized. So did you find that quite easy to do? And I'm wondering what the team in Fort Portal would think about that as well, because we discussed it yesterday.
I think unless you've identified the case when the mother has not yet been discharged, you can easily ask her all that information before she goes. But if you find the file after the mother has gone, that's when, like what we did today, we had to, okay, like when we were finding out from her, we called her and said, oh, how is the baby? We are checking whether the baby is now fine, whether they have to come back to hospital. And then that's when we were able to ask a few more things we thought were not captured in the file. So maybe it's either way. If the case is identified before the patient is discharged, maybe they can get all the information from her so that they don't have to make like a follow-up call. I don't know what the rest think.
Would you like, is there provision within the patient notes to capture this information normally? Or is this something that you would have to do on top of the patient notes? Because the reason why I'm asking is we have to be a little bit careful at the moment. We haven't yet got ethical approval for the program. And so if we are analysing secondary data, so the data that is already available within the facility, then that's no problem. But if we are now collecting new data, and it is ethically challenging data about people's socioeconomic status, their relationship status, their children, we need to be a little bit careful about that. So if you think it could be considered to be normal health centre policy to collect the information, then it's okay. If you are collecting this information just for the purpose of this project, then we need to be very careful.
Yeah, I think that's
sorry. Can you hear us again?
Yes, we can, yeah.
We were just going to say, we do as part of booking, I mean, it depends on the health centre, but one of the standard booking questions is what's the occupation when they book their pregnancy. But diving deeper into their socioeconomic status does require extra questioning. It's not something that is routinely captured at Fort Portal. We do call them to follow up, and also just for things like where we want to double check and see how many VEs they had. I don't think that's a question that couldn't be asked. I don't think it's anything wrong with saying to mum, like, how many VEs did you have, just so we can compare it to what's documented. But we can ask her about socioeconomic, but that would be additional information we're asking separately. It would not be something captured in the notes.
Okay. I mean, I think it's really, really important information, really interesting, and obviously has a massive impact on the patient outcomes. But for now, I think we need to be a bit careful about asking that level of information because we just don't have approval to do so yet.
Unless it's something that the mother has commented or that the midwife has documented, like waiting to go to theatre because patient can't afford sundries, then you've got a bit of an idea. But it's not routinely asked on our side.
Also, just to add something small, when a patient comes in, even the patient files, there is that provision of social history, like Tiggy has mentioned. It helps you know if the patient can afford some things, or even if you to prescribe like more expensive medication, you could reconsider and get something that's within their lane. So maybe it's not done because sometimes the numbers are overwhelming. So really someone going into detail to ask, are you staying with someone? They could just ask, are you married? And they leave it at that. They may not go on to ask if you the children share the same father or something, but it's not like it's outside the guidelines that we follow or the clerkship that we do. It could be captured under social history, but it's not done because that's a lot of work for people who have very many numbers at the facility.
Okay, so it's something that we probably need to wait to continue to do. So I just think for future, there's nothing wrong for this one because we're still learning and it's still a scoping exercise. It's still a pilot project. But for the future case review meetings, we probably need to stick to the data that's readily available as secondary data until we have ethical approval. And within that ethical approval, now the whole purpose of doing these case review meetings early is so we can pick out the interesting factors that we need to capture. So now when we apply for ethical approval, we can factor that into our ethical approval application that we will be asking for this data moving forwards because it is above and beyond what is currently available. Yeah.
I've got a few questions, if that's okay. Daisy, this was brilliant and it's so thorough and so full of information. It's really helpful. I just have a few comments and maybe for discussion and a few questions. And some of that probably comes from me being English and not Ugandan. I'd commented when I was writing notes on the no fetal heart rate on admission, but you'd also commented on that and also on the fact that no doctor reviewed at any time in NNU. I had a couple of questions or comments around labour and a couple of ones around baby. My labour questions were around the definition of active labour. So from what I could see in the presentation, it said that she was reviewed and was 3 to 4 centimetres. And personally, I would always go down 3 centimetres. I know that in Fort Portal, our partograph still says we're saying 4 as labour, but I think the Uganda guidelines are now saying 5. But either way, 3 to 4 centimetres to me would not be active labour, it would be latent phase, because they're not a good solid 4 centimetres or more. So my first question was, if the cesarean was for slow progress in labour, I would question that because she's not in established labour yet, by most definitions of labour. And then I also, and I know that this is my Englishness versus what you're trained at school. I struggle with the phrase inadequate pelvis, and I know that you guys are expected to assess pelvises. But if a head hasn't even properly entered the pelvis yet, and we know that pelvises move in labour, I really struggle with the concept of diagnosing inadequate pelvis when actually the pelvis hasn't even been able to move for the baby to descend. It could cause obstruction if the pelvis doesn't move, but she was not in established labour. So I would question the diagnosis of CPD and slow progress in active labour because she wasn't in active labour. And then I think you said, all of this ties together, which is why I'm jumping. I think you said that she started contracting, please correct me if I'm wrong, around 2 o'clock in the morning on the 5th? Or date of arrival was on the 5th at night, but like, was it like 9 p.m. on the 5th, or was it 2 a.m. the day before on the 5th? Do we have any idea? Because obviously, whether, like, when we talk about prolonged latent phase, she came in at 11 p.m. on the 5th and then had a section at 2 o'clock on the 6th, that's only 14 hours of contractions, and to me that's not a prolonged latent phase. It does say there's no time, but I couldn't remember what time the first BE was, or if we know what time she started contracting. I missed that part, I think. But it didn't seem like a particularly long latent phase to my ears, but I might have missed the timing possibly. So like, do we have and I couldn't find it when I was looking online before, but do we have a definition of prolonged latent phase in Uganda? Because for me, like, I know that we worry especially around previous scars, but in the UK someone can be in latent phase for 3 days and we don't worry because it's latent phase, if the baby and the mum are well. So yeah, I guess I have questions around the decision for section if actually mum and baby were well because she wasn't actually in active labour, and around what we call prolonged latent phase. That's my first set of questions. Maybe we talk about that and then move on to my other set of questions around the baby.
Yeah. Thank you, Tiggy, for the input.
Can I, sorry, before you start, Dorothy, can I just ask, is anyone taking notes?
Yes.
Because I know we are recording the session, but we need to be taking some notes about these discussions and the questions being asked and what the answers are.
Yeah, so I'll mostly maybe say something about the pelvis. So this particular mother had been given a trial of SCAR according to the findings, but then the fact that she was in prolonged latent labor for 14 hours, when the doctor later reassessed, of course they first initially thought they would give her more time, but when you reassessed, you realize the pelvis actually could not allow for a normal birth. Of course, we know when you look at CPD, it's more to do with the pelvis and also the passenger, the baby, was one of the scans. Maybe could have estimated more than 3.5. Usually they don't really keep them longer, but of course when the baby is born, they'll either come in with either 3.5 or more, even less compared to what was estimated. So I think here really the decision was made based on the pelvis, and of course the doctors here help to do the assessment. We have a senior like Dr. Nyenje, who is a gynecologist, and also with the midwife. So it's usually a joint decision really to be made that this pelvis actually let out the baby, as compared to say one person. So I would think
I would still challenge the concept of slow progress in the latent phase, though. If the doctor is certain that baby couldn't get through that pelvis, then maybe. But having seen a big number of large babies come through pelvises that didn't seem like they were going to happen, and the amount of times that on our labour ward we see referral for inadequate pelvis and then a baby comes out of it, I think, but we don't assess pelvises in the UK at all. And I know that here there is more of a risk of malnutrition, which can affect pelvic development and that kind of thing. But we've stopped assessing pelvises because it's such an inaccurate thing to measure. And because pelvises are moving structures, it's not a good or easy thing to measure. Especially because a lot of the time it might actually be, as you said, passenger, it might be fetal malposition rather than the pelvis itself. And I was literally talking to Rachel and Angela earlier, when you see someone and they're 2 centimeters, and at that point you suggest their pelvis might be inadequate, but the head's not even in the pelvis yet. So the pelvis hasn't moved or stretched or changed its shape, and the head hasn't descended at all yet. Everyone in the future who examines her is going to examine her with this preconceived idea that this pelvis isn't going to let the baby through. So it's not something we're going to fix, and it wouldn't have an impact on sepsis, but it's a thing that I really struggle with in Uganda, is this assessment of pelvis, because I've had doctors examine women that I've examined and tell me her pelvis is inadequate when I've had absolutely no concern about the pelvis whatsoever, having been doing VEs for 15 years. and I find it really hard to get my head around. But I would still challenge that slow progress in latent phase, because 14 hours is not that baby. She was making progress. She went from a thick 2 centimeters to a thinning 3 to 4. That is a normal progress in the latent phase, because we don't expect 4 centimeters per 4 hours in the latent phase. We don't expect that progress.
Is it could that decision potentially to use the pelvis as an indicator of progress, could that be linked to resource availability? So, for example, if it was Dr. Nyenji doing the assessment, I don't know if it was or it wasn't, and he knows he needs to leave shift soon, do they then, could that then pressure a doctor to make a decision? Okay, there may not be a doctor here in a few hours' time. If this woman then needs to go for a C-section, we might as well make the decision now based on perhaps an inaccurate indicator, rather than waiting and letting the woman progress naturally and then potentially hitting issues if there's a staffing problem later down the line, especially if this was in the night.
Not really, James, because at least now we have a full coverage. There's a doctor in the night, so they tend to actually wait for the mothers, maybe make a decision depending on the condition, as compared to the fact that the doctor is leaving a shift. But also here, I think the challenge with previous cars, if they are left maybe to labor for longer, fine, she can be in the health center. You could find more complications, ruptures, because like this particular mother, the descent was really high. The head kept high throughout the time she was in hospital. So they must have been really parameters that made them decide to actually do a C-section.
Can I ask, sorry, just contractions, I don't know if you commented on them or not. Was she contracting like 3 to 4 and 10 lasting a minute? Had she actually started contracting properly yet? Was that, I might have missed you say it.
So I think the challenge that we found with the case was the documentation, because like you see, we are talking about all this is a bit of a speculation that maybe they found the baby maybe was distressed, because even the fetal heart was not recorded anywhere. Yes, so the problem was actually documentation, and we could not locate a photograph as well, maybe because the person was not in active labor already. So that's a challenge that we actually even noted. Most of the things were actually not really there. The information was missing.
Yeah, that's fine. Like we have that problem all the time as well.
So how this goes back to my.
Then the head won't descend because it's not. It hasn't got the power behind it yet because she's not in labour. So again, that's then a cesarean section for someone who's just not in labour yet. Anyway, sorry, James.
No, I was just going to go back to my original question actually about where you got the information from for this case. So how much of this information on this document that you've presented was from the patient notes, and how much is extra information that you've had to find out and add into this?
So most of the information that is in the case was actually from the patient's chart and the baby's chart and the operation notes. The information that we got from the patient was more of the social aspect. That's really all. But we found only 2 VEs in the patient's chart, and that's what we noted. If they did more than that, that's something we cannot be certain about. The time of admission, even as I'm sharing right now, was not documented, and we put those bits in bold. We just got the patient chart, the baby's chart, and that's all that we put here.
So my next questions are on the baby stuff. The baby was on NICU, but we were talking about baby having fevers. Is there capacity to do tests at all, or not? Do we not have? Our problem at Fort Portal is we don't actually have thermometers on labour ward and maternity and postnatal.
Postnatal we have.
Oh, there was a postnatal. We don't have them on maternity ward at Fort Portal. So was there a test to do temperature before referral to NICU? or was it just from
Sorry,
touch?
sorry, you're breaking.
Oh, is it better now?
Yes, yes, we can hear you now.
I noticed that there wasn't a temperature documented before baby went to the unit. So there was one documented when it got to the NICU, but before it was just maybe on touch. Is there a thermometer available on maternity ward, or is that the reason there wasn't one documented? Is that there is a thermometer?
No, they actually have a thermometer, but what we commented on was the babies are not routinely examined. So it's just the caretaker who felt the baby was warm and brought them to the nursing side. And yes, they did the temperature, but they only did it like twice. And then also we do not really have an issue. So the babies just are just at the postnatal ward with their mothers.
Right, I understand. So the kind of NICU care or the intensive care is given at the bedside with the mother.
Yes.
Right, that makes sense. And my next couple of questions would be antibiotics. So normally the standard, I think, is that if you think this baby might have sepsis, we should treat with antibiotics as soon as physically possible. Because obviously if it's not bleeding, I understand, yes, the temperature could go up. But if there's a high temperature, we should always assume sepsis rather than anything else. So was the reason that, or possibly the reason that antibiotics started because we were trying to treat dehydration first, or because they weren't started till day 2? But really, they should, like, the priority should probably be antibiotics over dextrose.
So I think because the baby was also non-suckling, so maybe the enrolled midwife thought about first resuscitating the baby, hoping that the temperature could go down and also exposing the baby. But I think since the temperature was still high, they decided to initiate the baby on antibiotics the second day.
I would maybe suggest that waiting more than like 1 to 2, because also you said you were exposed for 2 hours and the baby's temperature didn't come down. So I would say that actually, and I'm not a neonatal specialist, I'm also a midwife, but in the UK, if we think someone has sepsis, we ideally want to start antibiotics within 1 hour. Dr. Gloria, who's one of our neonatal consultants, I think said they should have antibiotics, I think, within 30 minutes of admission to the unit if we're going with query sepsis. So I would say that probably maybe this baby should have had antibiotics on day 1 of that temperature.
And maybe we need some clarification to guide the team on when to actually decide to give antibiotics.
Within the first Sorry, can you start again? We disappeared.
So, the challenge that we have is sometimes like the medicine is not readily available, and sometimes when they expose the babies or they give them dextrose, some of the babies pick up. So I think they always make, they don't want to rush to load the babies with like antibiotics, especially if a baby is already not breastfeeding well. So I think sometimes they do it, they give the dextrose and the baby maybe picks up and it's just maybe hypoglycemia or just dehydration. And they don't, because sometimes it's the,
I still think waiting until day 2 is quite a long. Waiting until day 2 is quite a long time. Maybe we need to ask our doctors to kind of review. I don't know what the Uganda guidelines are on it, but maybe our doctors need to review that as a concept, just because waiting till the next day, and that baby did still have persistently high temperatures. It was over 38 easily, and 39 is quite high, even for day.
Yeah. Also, in the presentation, we noted that this baby was not being reviewed. Sorry. We had also noted that this baby was.
I think I just said. Not
the baby was not being reviewed by a medical officer, just the enrolled midwife. So it was her personal judgment.
Maybe something to note, here most of the babies are managed by the midwives, to initiate. So the doctor usually maybe will come to review what has already been done. Of course, with such a case review and feedback, this is going to help us maybe decide if we are going to say, make sure that we don't wait too long, like you've suggested, Tiggy, that the whole day was really long. So we pick that up. And maybe we will ensure that in such cases of a temperature of 39, maybe we don't wait too long before we actually start the antibiotics.
Hello.
I wonder if the Fort Portal team is having some more connection issues. Just while they are reconnecting, I was just going to ask, have you got access to the schedule that Tiggy used for the Fort Portal case review meeting? Like the checklist?
No. No, I don't think we have it.
Okay. Let's see if they can reconnect. I heard Tiggy a second ago, but perhaps they've gone, because what Tiggy had was a checklist, which was created after the first case review meeting, actually, which they ran through and they assessed the case based on.
Have you got me? Do you think getting it? Sorry, baby, rather.
Hi guys, I think we've got you back now. Tiggy, I'm just wondering, would it be better to turn your camera off in case that helps the internet a bit?
Good idea.
Yeah, we've got you back now.
We've changed Wi-Fi for the third time. Sorry.
Okay, no problem. Uganda internet issues, eh?
All the fun. Normally it's great, apart from when you really need it. Sorry, I heard Daisy talking about that it's normally nurses caring for the babies and not doctors. And then I also heard James asking about the question set that we have for Fort Portal.
Yeah, I'll let Dorothy. I think it was Dorothy that was talking about the care for the patients. So you go first, Dorothy.
Yeah, so I think maybe we'll need some clarification, because like here, our case finding, we are basing it on, say, if you expose the baby and maybe give the dextrose and they don't respond, that's when we switch to antibiotics and then classify that as sepsis. But if you say every baby cell 39, we are going to have it hard to actually, maybe we'll find maybe we are giving every baby antibiotics. But to for now, we realize some actually get the dextrose and they recover well and they actually discharge before we switch them to what? to the antibiotics. Maybe we'll need some guidelines. I don't know which guidelines we are following for now in terms of diagnosis, because for now, much as the lab can be able to do a CBC, most of the time we even have stockouts of the cartridges, like the CBC machine is, then the cartridges are not available. So I think we are going to find it hard to actually look out for the prevalency if we cannot maybe come up to decide when to start the antibiotics and when not to give antibiotics.
My other question would be that although it's normally the midwives having to, or the nurses giving care, you've just said that you do have 24-hour of a cover, 24-hour cover of a doctor. So I know they'll probably mostly be in emergency or with labour, but if you have sick babies or potentially sick babies, my feeling would be that they should be a priority for the doctor to review at some time during their stay. I don't know whether there would be the capacity for that, but I would feel like a doctor should have some level of involvement, because midwives do significantly more here than they're expected to do at home when it comes to things like decision making around drugs and things. But I think maybe it's different here. The role of the midwife in the UK is defined as expert in normal. And once the baby's got query sepsis, that baby's not normal. So although you can do all the things, my question would be, should you have to, if you have got a doctor present? Because that's the point of a health centre is to have a doctor present.
So they're usually on call. To be honest, they work so hard in a day. Sometimes one doctor might do like 7 cesarean sections, there are others in the night. So they usually do the whole round in the morning, and then they are on call, like for emergencies, and also in case they're monitoring a mother and does not go through as expected, that's when they come back. But it's not that they're like physically present throughout the 24 hours, because they are the same doctors who actually work the whole week, and it's really hard to actually maybe get them engaged in doing ward rounds in between. So that's why the decision for the antibiotics was done on the following day. I can't tell if actually that justifies it, because it was still done by a midwife anyway. Yeah.
Yeah, I mean, I have a lot of respect for the fact that you guys have to do all of that, because at home I refuse to even put IVs up for a baby, because I don't see it as my job in the UK, because I'm meant to be an expert in normal. So the amount of things you guys do, I think, is incredible. I think you're all amazing. I think I heard one of you comment also on the baby being discharged after 2 days of antibiotics rather than 3, 5, or 7. Sometimes we find at Fort Portal that babies get discharged just because they look well, like they seem well, and so we just stop using the antibiotics and send them home. But I think they get sent home on oral antibiotics. We got told as well by some of the doctors that often we have to discharge a bit early because we just don't have the physical space for the babies. Do you know why this baby was sent home before the completion of the antibiotics?
Yeah. That's right.
Yeah. No, it might be actually the capacity, because people are always delivering, so sometimes they don't want to have so many babies. And the moment they see that the baby picks up, and mind you, the mother had been discharged the day before, so she was waiting for the baby. She could also personally ask for the discharge herself, but we do not know why that actually happened. We just followed what was in the chart.
Fine. We're just seeing if your issues were the same as our issues. And then, do we know, because we started on dextrose, I don't know what your kind of infant feeding capacity for support is, because again, I know at Fort Portal there isn't really a midwife spare to kind of be around on the maternity ward all the time to help with feeding. But we started dextrose. Did we do any hand expressing, or like do they have dextrose alongside trying to breastfeed? What normally happens?
Yeah, go ahead.
So in our case, in this particular case, what we noticed was they started the baby on dextrose, but they probably encouraged the mother to trying to breastfeed. We don't know if they expressed or something like that, but we noticed later on, the second day, the baby had tried breastfeeding already, and still the temperatures were high. So probably they encouraged the mother to keep breastfeeding while they were also giving the dextrose. But those are sort of like assumptions. Yes.
Do you
And
much
in
hand
most
expressing with women for express milk?
Sorry?
Do you do much hand expressing? If babies are struggling to feed, are women encouraged to hand express?
Are they encouraged to express them?
sometimes, but you find in most cases in the first few days after birth, like the mother doesn't have enough breast milk. So sometimes expressing the milk becomes hard. That one can be done later if the breast milk is there and the baby is unable to breastfeed.
So
Yes,
in the UK, when we talk about hand expressing, you have colostrum for the first 3 days, right? So it's not high in quantity, but it's really good for you. But we also talk about it being supply and demand. So the more that you request the breast to make milk, the more it will. So we encourage our women, if their baby is struggling to feed, we encourage them to express every 2 to 3 hours, or 8 to 12 times in 24 hours. So it might be 2 hourly during the day and then 2 or 3 times overnight. Even if they don't get a significant amount out of the breast, simply the stimulation, so the massage and the nipple stimulation, helps to feed back to the brain that it needs to increase its quantity. And so we find that women who start hand expressing early, if their baby is not feeding well or is separated to NICU, they end up with a better outcome when it comes to milk supply and feeding than those that kind of don't do it because they don't think they have anything, because then it becomes a bit of a self-fulfilling prophecy where they don't think they have any, so they don't do anything, so then they don't request their body to make it, and then they don't make as much as they could. So that's why I was asking about express milk, because it can help to build up a supply so that when the baby's ready to go on the breast, it has more there. That's why.
This particular mother had a C-section, and of course it's really different as compared to the normal births and the ones who have had a cesarean section in terms of latching. We all know after the C-section, the position is really not adequate for like the baby to latch. So yeah, we do encourage them to actually try to squeeze the milk into the baby's mouth, but it's difficult, especially if they are still recovering from the C-section.
Yeah.
Sometimes it's just the position on how the baby is actually latching on the breast as compared to not having the milk itself. So we work around mostly on attachment and also, on how the baby is the position and attachment really does well also compared to the especially for this mother, it was difficult. The fact that she had had a C-section, of course, the first really hours were not easy to latch, but then after, the baby was able to latch well. So, but of course, it's good to really learn from what you're saying, that in other cases, if the mother is struggling to feed, we can always encourage that 2 hourly expressing.
Yeah,
Thank you so much.
12 times in 24 hours, so 2 hourly in the day, but then like maybe 2 or 3 times in the night as well, so that they're not waking up every 2 hours at nighttime. And also the kind of trying to imitate, we call it cluster feeding, you know, like babies that kind of want to eat on and off, on and off, on and off in the evenings. So like they might feed for 5 minutes, sleep for half an hour, feed again, kind of trying to imitate that snacky feeding a bit in the evening, because that gets a higher number of stimulations in the evening, so you can have a bigger stretch of sleep at night. Yeah, I had 2 more, but I've forgotten one of them. So I have one more question. Oh no, I do have 2. Sorry, and then I'll stop asking you billions of questions. You were talking about breast cleaning. What's the reason for breast cleaning here? Because again, at home, we actually actively encourage people not to wipe their chests. And when they have a shower after birth, we encourage them to kind of not use a soap on their chest and not not really wash their chest too much, and definitely not wash the breasts, because the areola secrete a smell like the waters, so it helps the baby find their way to the breast. And also we all have our own natural good bacteria on our skin, and when the baby licks on the skin, they ingest good bacteria from the mother's skin that helps to line their stomach with good bacteria, which helps to prevent infection. So I was interested to hear that we were asking people to clean their breasts, when I would often think to do the opposite, and I didn't know what the reason was.
Anyway, I don't think it's routinely done, Tiggy, to be honest.
Okay.
Yeah, to say that they have to clean, but naturally some people will come in with some towels, like they prepare a specific towel and a bucket and warm water, and they feel the process of labor, because here they don't have enough bathrooms to say they'll go and shower. So sometimes maybe she showered in the morning, ended up with a C-section in the afternoon, and in the evening she's back on ward, she cannot bathe, there's no bed bath. So someone really feels that they are dirty and they don't feel comfortable to actually breastfeed the baby immediately, and they feel maybe they need to first wipe a bit. So it depends really on the different mothers would do it differently. There are those who prepare those towels even prior, just to make sure they are not giving their baby like a contaminated breast. But it's not something that is
contaminated with.
Because if someone has not bathed for the last 24 hours or even 20, I don't know how many hours.
If we're talking about shower, like a kind of like a wash, a bucket wash, then that makes sense. That's fine. That's just, you just want to freshen up and feel not sweaty and gross. But if it's like actually specifically targeting the breast, I don't quite understand what it would be contaminated. Like, you're not rolling around with your boobs on the grass.
Maybe what
like here in our city, people are just told to go out and walk. We don't have space. So it means when they're examined and they're admitted, they actually not have a bed to say they're going to be in one place. So most of the time, really, they find they've around different places, and there's a possibility of someone picking up nosocomial like organisms. So there are few who will be curious and don't want to breastfeed their babies before cleaning up, and you wouldn't really say no. But there are those who will really like just breastfeed.
Fine. I was just trying to work out if it was like a standard practice or if it was just cleaning themselves up. That's fine.
Yeah, maybe another thing is these mothers, you may find she's using one bra for maybe a long period, and is washing it. And another thing is these pregnant mothers, most cases they don't like to shower, especially when they are near their labor time. So it puts the breast at risk.
Okay. But then once she's had a wash, you don't then have to clean the breast every time before you feed the baby, because once you've washed, you've washed.
Yeah, I'm just looking at if a mother comes in from home and she has come in late, she's going to second stage.
Yeah.
That means she's not being given time to first go to wash.
But like, as in, she's delivered, the attendant's holding the baby, she has a wash. You wouldn't like, people don't like wash their breast before every breastfeed, because once she's had a wash, she's clean. Like,
I think we might have to put this one down to some culturally different practice. I think just in the interest of time, we probably just need to move on a little bit, because I'm aware.
I've got one more question.
Yeah, sure. Just 1 second though. We knew this first meeting would go on a bit longer anyway, but in the future we wanted to keep it, roughly within an hour, didn't we? So if you ask your final question, Tiggy, and then Tiggy, have you shared a copy of your checklist?
I forwarded it on to anyone that was in the email that Rachel had sent before, so I'm not sure if it made it to Kampala or not, but I can.
Okay. Sorry, go ahead and ask your final question, Tiggy.
My last question was just around blankets. I assume it's probably quite similar to here. I noticed that the babies are often wrapped in a lot of layers. Do you find that that's the same at Kasangati? And do you find that often exposing babies brings their temperature down quite quickly? Like, do you think that a lot of babies that feel warm are overwrapped, or do you think more often it's to do with dehydration or sepsis?
I think it's the wrong thing. Personally, I've seen some mothers actually wrapping the babies so much, and I think at some point they cannot even breathe. So sometimes you just have to, you want to just advise them to keep the baby warm, but not make them hot. And I think that's why they encourage them to first expose. But I think it's also a common practice here. They use a lot of clothes, like they overcover the baby.
Okay, cool.
Yeah.
So we have the same thing there as well. James, did you want me to share that thing? Like, did you want to go through it now, or did you just want me to send it to them to fill in another time?
If you've got the template to hand, I guess if we could run through it quickly now, if we can try and be as quick as possible about it, just so then it's kind of done.
Yeah, give me one.
Might be helpful.
I actually think
So just for your benefit, Daisy and the rest of the team, this was a template that was created after the first case review meeting in Fort Portal, just to assess each case against. So we've got a standardized way of assessing whether the case was dealt with well, whether there were some missed opportunities, and in that way we'll be able to track across all the cases. Are there common themes coming out that we can then pull together a training intervention to focus on a bit later in the project? So it's about learning what's going well, what's going wrong, and then we can use that as evidence then to create a training package.
Who shall I send it to? Should I send it to Daisy?
You could just read it out. Oh no, you're on your phone, aren't you?
No, I can do it, but I just thought they'll want it in the future. So I thought I've got a blank template that I can send, so that then they can keep using it in the future. I'll send it to Daisy and Dorothy. Neonatal sepsis. Blank discussion. I think that should send to you now, and then I can fill it in. If I fill in the question bits, and then I could maybe send it over, and someone else can fill in kind of the discussion part that we've had. So also within it, we've just put in a summary of things that we think are risk factors for neonatal sepsis, and also the normal ranges for vital signs. So the first question is, was this an appropriate mode of delivery? Which I've had questions about.
I think from our previous discussion, that was a bit of a question mark, wasn't it, Tiggy?
Yeah, I'll put unsure.
Unsure.
Were there any risk factors for neonatal sepsis? So I think we were saying low socioeconomic status. The things that we've listed as our risk factors are a maternal UTI, prolonged rupture of membranes over 18 hours, offensive smelling liquor, prolonged labour, but we don't actually have a definition for that. Intrapartum maternal fever, multiple digital vaginal examinations in labour. There isn't a very clear definition of many. One study says 3 or more after rupture of membranes, but she only had 2. I would say no. Meconium stained liquor, maternal sexually transmitted infection, abnormal vaginal discharge, prematurity of less than 37 weeks, resus at birth for the baby, low birth weight of less than 2.5 kilos, and an APGAR of less than 7 at 5 minutes, and then a low socioeconomic status. So I think that was the only one I heard you mention. The next question is, did the mother have any prophylactic antibiotics? Yes, she had. You said ceftriaxone for the cesarean section. Are you guys still with?
Yeah, that's okay. Yeah, so according to this case, there's prophylactic antibiotics given, which were prescribed by the mother prior to the operation and also after the operation. All the mothers are given prophylactic antibiotics.
Was the prophylactic before cesarean ceftriaxone?
Yes, please.
Fab. The next question is, so the reason that this question is in is because in Thought Portal, I have frequently noticed that the number of VEs documented is very, very different from the number of VEs the woman has actually had. So the question is, were the number of VEs documented the same as the number the mother reports? So we've got 2 documented, but we don't know how many the mother would report.
I think it becomes sensitive because James had said we cannot call the mothers, the fact that we don't have ethical approval for that. And of course, we know that not all VEs will be documented. So I don't know how we can easily go about that to get the actual number of VEs that were done. Because the only way you could find out is if you ask the mother, but I think we've been advised not to actually call them.
James, what do you think? I mean, whenever I look after a woman on labour ward, I ask her how many VEs she's had. Like whenever, well, literally I take over and I say, and how many VEs have you had so far? Because I want to know what number VE I am doing. And then I document it in the notes. Mother reports she has had 8 VEs so far. 1 has been documented. But James, I don't know. Is it okay for us to ask the mother how many VEs we had?
I would say it is, because you guys are healthcare practitioners working within the facilities, and the numbers of VEs are captured within the existing data. So you're only qualifying the data that's written on the book. So I don't think that's asking anything else outside of what we already have available as secondary data. I was more saying before that we shouldn't really be calling the mother or their family asking personal questions about socioeconomic status, because that doesn't fall within the usual records held by the hospital. So that's why it's above and beyond what we should be collecting. But VEs are captured, so I think it's fine.
So maybe Tig, if you can ask, does it mean all the other midwives also write the number of VE they are doing, or it's only you doing it?
That's a personal practice because of what I've noticed. So it's something that I personally do.
But then
I thought every time a woman was examined, that should be written in the note, shouldn't it?
It should, James. But the other day I looked after someone on a Tuesday who'd been admitted on Sunday, and she'd had 1 VE documented and she'd had 8 VEs done.
Yeah.
So knowing the hospital, I was like, you've been in for 3 days. I highly doubt you've only had 1 VE. Mama, how many VEs have you had? And she said, I've had 8.
So I think we could, within this project, I think it's fine for you as practitioners to ask the woman, when you are working on her, for want of a better word, how many VEs have you had, and cross-check that with the notes, because again, it's not asking anything else than what you should be asking as midwives anyway. So that's fine. I think you can ask that question.
So we do ask them after, like when we pick the case, we do ask them afterwards.
And just building on what you said before, Daisy, one of the problems we know is a big problem in Uganda, not just for this project, but across the board, is documentation. And we were aware of that before this project even started. We wrote about it in the application. And one of the aspects of the training package, which we will develop, will be focused on patient documentation and patient pathways. So I think capturing any discrepancy between what's noted, whether it's temperature, whether it's numbers of VEs, whether it's the weight of the baby, capturing that is really, really important. And it does fall within the frame of what the hospital should be capturing anyway as data, so we can do that. And it's important that we do.
The next question is, what were babies' presenting symptoms that triggered referral to NICU? So obviously for you guys, there isn't a NICU to refer to, but I guess we would take that as triggered referral for further care for the baby. So from what I remember, it was that baby had a raised temperature, not feeding well, and was lethargic. Is that correct?
Yes.
Raised temperature on touch was the reason for referral, and then we did a temperature for real. So raised temperature on Jerry. Lethargic, poor feeding. Fine. And then were any measures taken for baby on like before escalation of care? We've got on postnatal ward. So baby was exposed did you say for 2 hours?
There are questions. They came up with.
Baby was exposed for 2 hours. Is that right?
Yes, the baby was exposed for 2 hours.
Was there feeding support given before you decided to escalate the care?
Sorry, was the feeding what?
Was there feeding support given before you escalated the care, or was it more after care was escalated?
The reason as to why the caretaker had brought the baby to the midwife was because the baby was not feeding well. That
Yes,
was actually before the care.
So our question, because we have a NICU, so we've got what are the baby's presenting symptoms that triggered referral to NICU. So at Kasangati, the question would be that triggered escalation of care. So the midwife saw the baby, the midwife exposed and did a few things, but at some point the midwife then made a decision, I need to escalate this care, I need to start cannulating, giving fluid, giving antibiotics. So the question for you guys, we have to kind of adapt it slightly. So we say, were there any measures taken for baby on postnatal before referral? Yours would be what things were done before escalating to IV access and dextrose. So you said you exposed for 2 hours. I'm just wondering, was there feeding support given before the escalation to IV access and dextrose?
Yeah, I would like to believe that was done. However,
Well, we don't have it
I cannot
documented.
speak because the documentation is actually not there.
That's fine. So we'll just say exposed for 2 hours. That's great. And then was this an appropriate admission to NICU / escalation of care at Kasangati? Yes, I think it was. We had a raised temperature. Can I check? Sorry, was the temperature was done before we started cannulating?
Yes.
Yeah. So we also did vitals or temperature. And then were there any delayed or missed episodes of care for the mother or for the baby? So for the mother, there was no recorded fetal heart number. You said there was no partograph?
Yeah.
But she was it before the photograph. She was
She was not yet in active labor.
That's true, but they said she was.
She was just
That was, I
starting.
think, like an error. 3 to 4 centimeters. She was not yet in active.
If they documented impression active labour, if they documented impression active labour, then they should have started a partograph.
That was not done.
So no partograph. And she also, guys, also, I don't want you to think that I'm being super critical. Like, the point of doing all of this and the point of asking these questions and the point of being really picky about was this done, wasn't this done, is to try and find trends. So if we find that throughout the course of this, even across Fort Portal and Kampala, that we are struggling to do regular vitals on baby, or partographs are regularly not started, that women are not having the right number of VEs documented compared to what they have. Those are things, as James said, that we really need to then focus on in our work to reduce sepsis, because they are things that then can cause risk. like our NICU was telling me that they sometimes they do the baby vitals, but then they just don't document them. And it's good that they do them, but no one can follow up that care if it's then not documented. So then we want to try and think of, is there an easier way to record, to document those vitals so that they can be done recorded more frequently. So it's never a criticism or an attack. It's 100% for learning and to see why did we, because sometimes there's a good reason for doing something a different way, sometimes there's not, sometimes it's human error and human factor, like I'm a human and I forgot because I was looking after 30 babies. So it's the reason that we're picking at these things is to see if trends emerge that can then try to be supported, or if we can be creative about thinking of a way to mean that things can happen more fluidly or easily. So we were also talking about how mum had come late for her first attendance. She didn't come till 30 weeks. That's not necessarily something we can control, but it means that she missed some of her episodes of care antenatally. And would have missed medications and things like you said as well. And then, is there anything else on mum's side that was delayed or missed? It sounds like everything happened quite quickly and efficiently.
Maybe because the time when most things were being done was not documented, we cannot really ascertain those delays, like the time of admission. We were just approximating when they went to theatre using the
Yes.
documents, the recordings for the anesthetists. So it might be hard for us to ascertain some of the things.
That's a really good point. And then for the baby, you had a few things you'd written down. You were saying that baby didn't, although the plan was for a certain number of doses of dextrose, they didn't have them all?
Yes, the midwife had made a plan of the baby receiving every 2 hours, and for the first day they only got 3 times, so they ended up getting after 8 hours.
Sure. Do you know what, when you have an unwell baby, oh, you said that baby didn't always have a full set of vitals when you did the temperatures, they didn't? Yes. Did they do rests and heart rate as well?
That was not actually documented. It was just the temperature, and I think they only had 2 readings.
And then no further vitals were done for the baby after those first 2 temperatures? Oh no, there was, because there was the 39 and the 38.8. Were there any more after that?
No, one was on the first day, and then the other was on the second day. Yes.
And then not on the 3rd day?
No.
What, if you have an unwell baby, what is the kind of aim, what do you aim for with regards to frequency of vitals? Do you aim for once per day? Do you aim for more frequently? It may not be achievable, but what's the gold standard? What would you do in an ideal world? What's the guideline at Kasangati?
I think it would depend. You would have to triage and see. For a very sick baby, you may not even want them to go back to ward. You may want to retain them in the court at the labor suite, maybe where the midwife is stationed. So for a sick baby, you may not even want them to go back to the ward. But if the baby is slightly stable, depending on the human resource available, you could estimate, maybe you could start with 15 minutes, take it to 30, move to like 1 hour, 2 hours. You keep increasing depending on the vitals that you're actually getting, if they're becoming more stable, and also with regards to the human resource that's available.
Okay, so there's not like so again, like at my trust in the UK, any baby that's on IV antibiotics has 4 hourly vitals. And like any baby where there's been meconium in the liquor, in the water, has 2 hourly for 12 hours and then 4 hourly for 12 hours. There's not like a protocol like that. It's more on kind of a midwife's assessment of the baby. Is that right?
I think it's kind of similar, but you would assess and see depending on the condition of the baby.
Okay, but there's not a standard for what you should do.
But what we have been doing is that at least we have been every shift, because we have 3 shifts, whoever comes on duty makes sure that like they take those vitals, the mothers and the baby.
Fine. I'm just because also Dr. Gloria, who is one of the consultants on our NICU, she said that on the NICU at Fort Portal, the aim is, or the ideal, the standard is that a baby should have vitals every 2 hours if they're on NICU, or if they're admitted to NICU with query sepsis. But the reality is that we aim to do them once a day because they don't happen every 2 hours. But we always, if that baby should have them every 2 hours and can't, we still we pop it on this as a missed episode of care, just because again it builds that picture for us of what is expected and what is reasonable, and then we can try and kind of come to a better standard of what we can do. Does that make sense?
Yes, it does.
So that's why I was kind of asking. So what is actually done is they're done, aim to do them every shift, but is there a guideline that says it should be done a certain number of times, or is the guideline at Kasangati every shift?
I think the ideal, every time if they are to get their dextrose 2 hourly, maybe if they come in for the dextrose, they would be actually checking their vitals. But sometimes maybe because of the human resource, like here, the nurse who is on evening shift, the midwife, will manage both the sick babies, the postnatal mothers who are on cesarean, those laboring. So I think because of the limited human resource, they end up not doing what is the ideal.
It's completely understandable, like completely understandable. It's just trying to look at like what is the aim or the standard in our setting, and what do we actually achieve. And the reason might come up. I'll explain it later. You'll see. Anything else for the baby didn't complete was it prescribed for 5 days of antibiotics or 7?
You only had 2, but maybe at least the list would be 3.
Okay, so didn't complete full course of antibiotics. Fine. Anything else with baby? I think that's probably everything.
Maybe.
Yeah.
Me, I would like to clarify on like if someone comes when she's to St. Meters and maybe she doesn't have any other sign of labor, and we have decided to give her around like how long, like how frequent should we do the vaginal examination?
If a woman comes and she doesn't have any signs of labor, we shouldn't examine her in the first place. Because if she doesn't have any symptoms or signs of labor, there's no good rationale for a VE. Yes. Because remember, the definition of labor is contracting 3 to 4 in 10, strong, long, and regular, with a cervix of 4 or 5 centimeters. But if they haven't got those contractions at all, if they're not contracting, they don't need a VE. I guess here I know that we do Are we back? Sorry, we switched Wi-Fi again. I know that we do examine if someone's waters have broken here. So if their waters are broken and they're not contracting, if we have to do a VE because that's protocol, then fine. But then I would actively avoid doing another VE until either they were contracting. Are we with you? Hello?
Yes,
Hello.
please. You're breaking.
I know.
The things you're saying. Sorry.
Hello, are we with you better now? Can you guys hear us? Are we with you now?
Yes. We can hear you now.
Cool. Sorry, Richard had to take his Wi-Fi away, so we were switching back and trying to find a good one. I don't know where I got to before we cut out.
We didn't hear most of the things, so.
I would say that if someone comes without any signs of labour, then we shouldn't be doing a vaginal examination. It's not necessary, because if they don't have any signs of labour, there is no clinical indication to do a vaginal examination. If they don't have strong, long, regular contractions of about 3 to 4 in 10 lasting 40 to 60 seconds, they are unlikely to be in established labour, because the definition of established labour is strong, long, regular contractions and a cervix of about 4 or 5 centimetres that is effaced. So if someone came in contracting 2 in 10 minutes for 20 seconds with no other concerns, the waters hadn't broken, no membrane rupture, no bleeding, normal vital signs, normal fetal movement, I would be inclined to ask them to go and get some lunch or some breakfast and just relax for a while and see what happens with their contractions. If they're a para 9, maybe examine them.
People are different. There are people who just have very mild contractions, and by the time they're on the bed, they are 4 to 6 centimeters. So if someone has show, or even just the mucoid discharge and any cramping like labor-like pains, you would at least do the first V and maybe delay the next one, but you wouldn't ignore some.
It depends on it depends on who they are as well. If they're a primip and they're having a tightening 1 in 60, they can just wait around for a bit longer. You can just see what their behavior does for a little while. If they are a para 9 and they're cramping a tiny bit, but 2 in 10 for 20 seconds, yeah, you might want to do an examination on them more quickly. But then if they are not in established labour and nothing changes, they don't need frequent VEs. Like Bahinga, I would often say to them, go rest on the ward and come back tomorrow morning. If it's the afternoon, come back tomorrow morning, unless anything has changed overnight. So if you start contracting more, if your waters break, if you start feeling rectal pressure, anything like that, come straight back to the ward. But otherwise, my VE is not going to make her labour go any faster. It's not, knowing that she is 2 and then 3 doesn't really make any difference to me. But I also don't routinely examine people if they start pushing either. So are you okay if I move on to the next questions?
Excuse me.
Yes.
I had set the meeting to end at 4. I don't know if it will just go off, but yeah.
It might do. Let me just double check. That's okay. Did we order a CBC or did we not order any bloods?
We didn't do any tests. We didn't run any tests. The cartridge was not, yes, it was out of stock, but that's also not routinely done.
Okay, so we didn't have any doctor's reviews. I can fill some of this in for you. Treatment given appropriate. One of the questions is, was the treatment given appropriate? Yes and no. My feeling would be that probably the antibiotics should have been started a little earlier, but then it did have dextrose and antibiotics. So overall, yes, it was appropriate, but my feeling is maybe it should have been started a little earlier, maybe. The next question is, was the treatment completed? The answer is no. Baby went home before antibiotics were finished. What further investigations would have assisted with this baby's care? I'd say probably CBC, maybe a CRP, maybe blood cultures. Was the discharge appropriate? Probably. We've been quite harsh with ourselves in Fort Portal. So where the baby went home before antibiotics were complete, we would say no. It doesn't mean the baby wasn't well. It doesn't mean the baby isn't well now. It's just if we haven't completed a plan, then baby's probably not ready for discharge technically. What was the grade of the person discharging the baby? Yeah, was it midwife, enrolled midwife, doctor?
Yeah, it was a name or
It was
The baby was discharged by the midwife.
the MO discharged.
The mother.
The MO discharged the mother and
The MO discharged the mother.
discharging the baby, the
Probably,
person discharging the baby.
I think an enrolled midwife.
Guys, I'm really sorry, but I'm going to have to drop off this call because I've got another
Rather
meeting
like-
starting in
fine.
1 minute. So, Tiggy, if you wouldn't mind just finishing that checklist, that'd be really helpful. And if you could circulate that, and hopefully the guys in Kampala can complete the rest, fill in any blanks, that would be great. And then the other thing I just wanted to ideally for the team to agree is when the next meeting will be. I don't know whether you found it useful I'm talking to the Kasangati team now, whether you found this useful, but it will be good to agree when the next meeting will be and how often you would like to have these meetings, or if you don't want to have these meetings, then that's also good feedback. So perhaps Daisy, if you could speak to the team about that and agree when the next meeting will be and how often you want to have them moving forwards, and let me know, that would be really helpful.
Okay, I'll do that.
All right, perfect. Thank you, everyone. Thank you so much for your time. It's been really, really interesting, and I'm looking forward to hearing more about it.
Thank you so much, James.
Thank you. Goodbye.
The next question is, bye James, could any other care have been beneficial? So I think probably just the blood tests that we couldn't do. Do you think anything else would have been beneficial?
Maybe more health education or to the mother.
And antenatal care for more of her pregnancy if she'd come earlier.
Yes.
And shall I put it just because we can't be sure either way, possibly some more feeding support?
More feeding support?
I don't know whether she had good feeding support or not. I can put possibly more feeding support because we don't know, it's not documented.
Yeah.
I think in the UK, we say if it wasn't written, it didn't happen. So I generally work on the fact that if someone hasn't written down that they've done the care, then we can't say they did it. So we assume they didn't, even though we know they might have.
We assume the same thing.
Yes. I'm going to leave. The next question is noted points of good practice. I'm going to just copy and paste it. I'm going to email this to you, copy and paste it from your presentation into this box, rather than me typing it all out. The next question is, did this patient receive the best level of care possible within the constraints of this setting? And then we ask why. If we say yes or we say no, then we say why.
They receive the best care from popular family.
So far, we've not said yes yet in Thought Portal. We've always said thanks.
We are thinking we could have done more. We had so many near misses, like monitoring the vitals. If this was a very unfortunate baby, something could have happened and wouldn't have caught it early. And then the documentation, it really does not give the exact picture.
Yeah.
So I think probably no.
I think for this one, that probably no. And it doesn't mean that the care the baby received wasn't good. Like, it looks like baby actually received very good care, and mum. It just, if we're never perfect. And so the likelihood is that almost always the answer is going to be no, because there's always something we probably could have done better. But hopefully that's why it's good for us to do these kind of meetings, because then we can think, what can we do better? Give clear picture of care. Any other questions? So then there's a section that says any other questions. That's probably where, if you guys wouldn't mind, you pop in some of the discussion points we had. So pop in the question, pop in the answer, any comments that we had. And then the last thing we do is if there's any action points that need to come out of this case review. I'm not sure. Oh, you were going to try and clarify a bit more on like at what point you should initiate antibiotics after a high temperature is found. Who would like to be in charge of that?
Yes, I think we had agreed on that.
Who is going to do that clarification?
Doreen is going to be in charge of that.
Oh, sorry, hello.
Moving forward, how can we be able to capture the misty documented number of VEs? Can maybe one of the midwives start a practice of numbering the VEs maybe they're doing, so maybe the others can also learn to say this is VE number this. I don't know how you've done it in code, but it would be good for us to pick a leaf, or else they will still be like.
We don't have a good system. In Fort, a large number of our VEs are not documented. So one of our action points is to try and encourage people to document their VEs more accurately and consistently. But right now, it is not done well. But what we do is when we're doing our presentations, we just ask the mother. We ask the mother how many VEs she had, so we can compare. But I can. Sorry, I didn't hear. Who is going to clarify at what point IV antibiotics should be started after a raised temperature?
That's Doreen Babazi.
Doreen. And when will she do that by? What time frame are we giving that?
I think I'll begin immediately. So I think in 2 weeks she would have given feedback in 2 weeks.
Lovely. Perfect. And then maybe we just put discussion with staff around documentation of VEs, and we can say that that's an ongoing thing at the moment, maybe.
I think that's a good idea.
But it's not something that has to, because it might be that as part of this project we do a bit of teaching on. It's part of that package that we're developing, is teaching on documentation and VEs. But for now, we can just start with talking with the staff of importance of documenting VEs properly. Can't spell.
I think
Brilliant.
also
Who would like to be in charge of that?
Davi is Ndagire Sar. Ndagire Sar, but also I think a challenge that came up was the fetal heart rate monitoring, not quantifying the heartbeats. I think as we're encouraging people about the VE, would also tell them to instead count than just noting that they've had the fetal heart. Get a Doppler.
You don't need a Doppler because the problem that I've noticed in Fort Portal, again, is that when we have a Doppler, people just look at the number. And the problem with a number on a Doppler is that it changes every couple of seconds. And then you just pick a random number. And that is not the fetal heart. The way that you record a fetal heart is by counting it for 60 seconds, whether you are using a Pinard or a Doppler. And I'm constantly chasing doctors and hiding the screen so that they don't just look at the number and make it up. To me, looking at the number on the screen of a Doppler is no more accurate than me just listening with my ear and going, yeah, it sounds like it's about 135. It's no different because you're just picking a number at random that you see on a screen. You're not actually counting.
So maybe just encourage them to count.
Yes. So Sarah is in charge of discussing with staff about the importance of documenting VEs properly and the importance of recording fetal heart as a number. And that's going to be an ongoing discussion with everyone. As soon as she sees them, she'll tell them. Lovely. If you guys think of anything else that you want to be an action point, then please do just add it onto this form. And then there's a space for you to put the next meeting as well. When I send you the form, you just need to put the people that were present for the presentation, and then fill in the table at the bottom. You just need to add the points of good practice and any other questions.
Okay. I think people don't have any questions here, right? Sorry, do you have any? We don't really have any questions here, but maybe we shall keep
in the section that says any other questions.
Yes,
that's where we document the discussion that we've had. So where, like, I've asked questions about active labour versus latent phase. We've talked about why didn't we start the antibiotics on day 1. We've talked about why didn't we have a doctor review, about breastfeeding, that kind of stuff. Those are the place that's where we record that discussion, is in that any other questions section.
Oh, okay.
Okay, so if one of you could just write a little summary of that conversation into that section, it just means that we've got a good record of the whole conversation. And then going forward, so when we do it here, Rachel or Angela will present and I will keep the record, I will do the typing. So then as people ask questions, I put them straight into that box and then type the answers so that we keep a record of the conversation we have.
I think that will be something good for us to adopt next time, so that we, as photo, we get it right there and then.
Yeah, it's helpful to do. But I'll fill in the little bits that I said I would fill, and then just go through it, check that you think I filled it in as you think it should be, and add your bits that I haven't filled. Is that okay?
I think that's fine.
But thank you so much. It was a really interesting presentation.
Thank you.
I really enjoyed these. Who shall I send this to so that I'm not filling inboxes with incomplete discussions?
I think you should send it to me, Daisy.
Who is me? Daisy. Yeah, cool.
Yes, Daisy.
I will finish it now and I'll send it to you in a few minutes.
Okay. That would be great.
Okay, thank you so much, guys.
Thank you.
Thank you so much. Thank you so much.
Okay, no worries. Talk to you soon. Bye.
Okay. Talk to you soon as well. Bye. Have a good evening and good weekend. Hello, Alan, are you still there?